Hey, everybody, this is Tom Sega from Duluth Pack, and this is the Duluth Pack podcast, Leader of the Pack. And today we have a very special guest. We have board certified oral and maxillofacial surgeon and senior partner of Northern Oral and Maxillofacial Surgeons, PA, and my good friend, Dr. Duncan Puffer. Duncan, welcome.
Hey, Tom, good to see you. Thanks for having me on. It's an honor.
It's an honor to have you on, and we want to learn a whole bunch about what goes into your career, how you got to where you are, and if any young people are listening and would love to take a path like yours on how they could also do that. But really, what goes into the life of an oral and maxillofacial surgeon? What's a day-to-day life like of doing that? So let's start, Duncan, with where you're from, where you went to school.
I grew up in St. Paul, Minnesota, but back then, where we grew up, my little neighborhood, was actually pretty rural. In fact, all my backyard was a 300-acre dairy farm with an electrified fence and cattle and ponds and hay fields and woods, and it was a great place to grow up. We'd leave the house in the morning in the summer at dawn and come home at dinner, and your parents didn't even worry about where you went,
Oh, you didn't have your cell phone then on you?
Yeah, no, cell phones were pretty late. And actually, I think our world would be a better place without them. But, we're so darn dependent on those things, aren't we?
We certainly are.
So I went to, grade school is Little Canada, and then high school is Frank B. Kellogg in Roseville. I graduated in 78 from that. It closed in 86 and combined with Alexander Ramsey, our crosstown rival. And that became known as Roseville Area School. So that's still in play. From high school, I went to Gustavus Adolphus College in St. Peter, Minnesota. Continued my football career there. And then went to dental school at the University of Minnesota after that.
And where you graduated with honors.
Yes.
So can we back up just a moment?
Yeah.
At Gustavus Adolphus, what did you major in?
My dad was a chemical engineer. I had a lot of respect for him. I kind of started as a chemistry major, but failed miserably. In fact, I really did poorly my first semester at Gustavus. Came from a high school, and I had pretty good academic success without much effort. Went to college, and it was a whole different ball game, right? Trying to play football and doing jazz band, I got a little behind. But anyway, I started out as a chemistry major and then changed to kind of a pre-dentistry major. And what made the difference for me is my oldest brother, Charlie, who was 10 years older than I am, he was a dentist at that time. And I didn't really know what I wanted to do, but I went and watched him work. And I thought, this is really pretty cool. You're helping people. It involves the sciences. There's some skill involved. It's doing things with your hands. And so if you're the type of person that likes to have that gratification of having a job completed, like you are kind of a hands-on guy, Tom. And I remember when we first met and you were building your house and you were doing a lot of that work yourself and stuff. I think it's really cool to have those skills. And so that's what attracted me to dentistry. So watching my brother kind of flip the switch, and then I decided, okay, now I have a goal in mind. Now I need to get ready for that, and made all the difference in the world for me. So I became a pre-dentistry major is what they called it at Gustavus.
Okay, and then so you get into the University of Minnesota, and dental school's 4 years, correct?
4 years.
And from there, did you practice dentistry for a while before you went back to school to become a surgeon?
No. In fact, I worked really hard in dental school, and I was enjoyed a bit of success there, and it opened up some opportunities for me to specialize. And back in those days, they used to require that you practiced in general dentistry for a year or two before you could specialize. But the stars aligned just right for me, and I was lucky enough to get into the oral surgery residency right after I graduated from Minnesota. So I got into the surgery specialty training at Minnesota.
Okay.
right after graduation. So,
And what does that look like? So you're a dentist,
uh-huh.
and now you're back in school to become a surgeon.
Mm-hmm.
What does that school look like, and how many years is that?
So I was the last of the 3-year oral surgery residencies.
Okay.
So after me, it became a 4-year program at Minnesota. There are dual degree programs around the country where it's a 6-year program. You basically do the last 2 years of medical school. You get credit for the first 2 years with your dental degree. And then you finish those programs as an MD DDS. So I have a couple partners that have gone that route at Mayo, but I was the last of the 3-year single degree guys at Minnesota. And oral surgery residency is kind of interesting because it's based in the University of Minnesota School of Dentistry, but also in the University of Minnesota hospitals and clinics, including Hennepin County Medical Center and the VA Center. So you have a series of 3 or 4 month rotations. And back then, my very first rotation was at Hennepin County Medical Center, which, is a public institution. And you might imagine that it's kind of busy in the oral surgery clinic, and it was. So it was a real interesting eye opener. Your days are very busy. You, right away off the bat, you end up taking call. So you're sleeping in the hospital. You have a beeper that goes off. You're sleeping next to other resident rooms, and you can hear their beepers going off through the wall. Basically, you don't sleep all night because you hear a beeper go off and you wonder if that's yours or not. So I spent a lot of time in the emergency rooms treating traumas of the face and the jaws, sewing up faces, repairing broken jaws and things like that. And then clinic in the day, just taking out teeth. In the meantime, then, in any spare moments, you're studying medicine, studying dentistry, studying oral surgery. But as a first-year resident, you're teamed up with a second or third-year resident, and so you're basically the low man on the totem pole. So if there's a big case that you're doing in the operating room, you're basically the guy holding retractors. But it's an opportunity for you to learn by watching. And the old saying in residency is you watch one, do one, and teach one, right? And that's how you kind of cement it in there. So that's what residency is like. They have many different rotations for us. So one of the rotations I did was a general surgery rotation, and that was actually affiliated with the Minnesota Spine Institute at Fairview Riverside. So I'd assist on spine surgeries all day long. I'd do the preoperative history and physical exams on their spine patients.
No kidding.
On the patients at night. So I would be there at about 4 in the morning, and I'd go home sometimes at 9 to 10 o'clock at night. I'd be doing surgeries all day long. Some really long hours, but you learned a lot.
So even though you are in the oral surgery path, you as part of your fellowship are working in a lot of different areas.
Yeah, they want to overtrain you, and they want to create in you a great broad depth of surgical knowledge and medical knowledge so that you can handle the demands and the routines of being an oral and maxillofacial surgeon. So in addition to the general surgery residency, I was assigned to a medicine rotation, and that was at the, I'm forgetting the name of the institution now. It was almost over 30 years ago, but it was in downtown Minneapolis. In fact, one of the guys on my medical team is my physician in Duluth.
No kidding.
Yeah, he was a third-year internist on our medical team. So they had him, and they had a first-year internist, and then they had me. And so the three of us kind of rounded together and took part in the treatment of these patients. And so it's kind of funny because I've known him ever since. And
what a small world.
Yeah. So anyway, and then another rotation that we would be on would be anesthesia. And so we would function in the capacity of a first-year anesthesia resident, and that was at the University of Minnesota. So I've done general anesthesia cases for kidney donations, total hip replacements, things like that. So yeah, it's a busy time. It's an eye-opening time. You're just flooded with all these experiences, and your job is to basically be a sponge and to soak everything up, using your eyes and your ears and your hands and reading as much as you can. You know, there's not really a set reading curriculum where if you read chapters A through Z and you take a test on it, then you're an oral surgeon. It's just you. If there's something that you don't quite understand, you go look it up, and that's how what you study. And
then I would assume ask a lot of
Yep.
questions of the people you're around and absorb, like you said, as much as you can.
I had some really great senior residents, and they were good teachers and they were good people, and I learned an awful lot from them.
And you reciprocated when you were that senior resident.
Well, I like to think so, and you'll have to interview some of those guys one day and see what they say.
We may have to, Duncan. We may have to. So then you get into practice, and you started out in the Twin Cities.
Yep.
For a short time, and then you come up to Duluth and you get into private practice.
Well, I was in private practice in the cities. What happened was two of my part-time instructors in my residency approached me and said, hey, we'd like you to come work for us. And so this was my first or second year residency, so I committed to that. One was Bob Branjard, and he's kind of a big name in dentistry because he was an oral surgeon in the Burnsville area for a lot of years. And then he was head of our own state professional association, the Minnesota Society of Oral Surgeons. Then he became president of the Minnesota Dental Association. And then
Wow.
he became president of the whole American Dental Association. So that was my first boss. And I worked for him for 3 years. And then I part-timed with a good buddy of his up in Brainerd, Vic Sophie. And what was great about that time was that, again, it was another sponge absorbing, knowledge absorbing experience. I got to work with two really great experienced oral surgeons, and I learned a ton from both of them. And I got to see how two different offices ran. In fact, when you're in oral surgery practice, you can kind of get into a rut of your own way of doing things. And one of the greatest ways to refresh and to upgrade your practice is to see someone else work and talk to them. And so meetings are good for that. But I had that experience early on working for two of my instructors and seeing how they ran their practices. And during the time I was a senior resident and committed to those two guys, Chuck Babst in Duluth had approached me. Chuck was 10 years older than I was. He was actually a classmate of my older brother in dental school. So they knew each other. So Chuck had asked me if I was interested in come up to Duluth, and I had to tell him at that time that I'm sorry, but I'd already committed to Branjard and Vic Sophie. And so Chuck and I kept in touch. In fact, even though I was working part-time for Vic in Brainerd and the rest of the time for Branjard in Burnsville, when Chuck Babst had a big corrective jaw surgery case scheduled and he needed an assistant, I'd drive up to Duluth and assist him on those cases. So I was going between Duluth, Burnsville, and Brainerd.
Wow.
Yeah.
So let me ask you a question, because I know you know one of our 1980 gold medal Olympian hockey players who's also in your profession in Brainerd, correct?
Yeah. He's actually retired now, and I've heard he recently moved back to his hometown of Grand Rapids. That was Bill Baker.
Yep.
So Bill, great guy, good oral surgeon. When we were in residency, of course, you know, we we'd do some intramural or pickup hockey games and stuff. And I'll never forget the time that Bill went outside with us and skated. There's just a different sound. You have a Hobie Baker skating up the ice. There's just a different sound that his skate blades make on the ice than everyone else.
Yeah, and the rest of you are saying, "Wow, he's really going fast. I thought I was."
Yeah.
I remember having that discussion with you that you knew him, and that was a pretty important time in our country, and to the gold medal Olympians, and to have one from Minnesota, and then go into a profession such as yours is pretty cool
and
deal.
Bill was nice enough to take me to Mariochi Arena, and so I actually got to sit next to a few of his other gold medal teammates at one game anyway that I can recall. But anyway, yeah, fun time.
Pretty good stuff. So let's fast forward a little bit here, Dr. Puffer, and talk about what really happens on a day-to-day basis for you.
So it's all about caring for patients, right? So on a day-to-day basis, and I'm in the clinic 4 out of the 5 days of the week, and the 5th day is either an administrative day or a day that I would do hospital cases or have a rare day off. But on a day-to-day basis in the clinic, our clinic starts somewhere between 7:30 and 8. And we typically will do surgeries in the morning. So we'll do surgery till noon. And then at 1 o'clock, we'll maybe have a couple surgeries. Then the rest of the afternoon is seeing pre-surgical consults and post-operative exams. And then at the end of the day, you get to dictate all that stuff.
All your notes.
All the paperwork.
So let's talk about the surgeries, because you're saying in the morning I do surgery. Yeah. Tell us what kind of surgeries these might be, because there's so many different types of things you do.
Sure. So the most common thing that an oral surgeon does is take out teeth, and so it's either taking out wisdom teeth on teenagers or sometimes wisdom teeth on older people, or just taking out teeth in general. But we also treat people who have lost teeth and want to regain function, and so we can do that by restoring them with some dental implants, which are basically anchors, titanium anchors in the bone. Oftentimes people don't have enough bone because once they lose the teeth, that part of the jawbone that held onto the teeth begins to atrophy with time. And so then we have to build back that bone in order to accommodate the dental anchors or dental implants. And then their dentist can build them teeth to go on top of those anchors. And the analogy that I like to use to help people understand that process is that it's similar, very similar to building a home with a basement. And in that analogy, I'm the excavator and the foundation guy. My job or my role is to get everything up to grade. And then I tell the patients that their dentist is the framing carpenter and finish carpenter. They build the house that when people drive by on the street and they say, "Look at that nice house," that's their dentist job. So it's a teamwork approach, much like building a house. And I tell the patient that your role as the patient is you're the homeowner and the general contractor, which means that you get to decide who you want to work with and you get to pay all the bills.
And that's exactly what they want to hear, right?
But it's a pretty close analogy, and I think it helps them understand the process. And I think it also points out that by having a teamwork approach, you get the benefit of people bringing their particular expertise to the project. Back in the early days in Hermantown, there was a builder that used to do everything all himself. And I'm sure you remember the name, but and that can happen in dentistry. I mean, there are certain individuals that are skilled enough that can do that, but for the large majority, I think there's a benefit to patients to have kind of a collaborative team effort to ensure the best possible care. So that's what we do. We work closely with other dentists. and to build back those patients. Some other things that we do in the clinic besides taking out teeth, reconstructing the jaw bones and in preparation for implants is we can treat certain pathologic conditions that may arise within the jaw bones or the jaw, either soft tissue lesions or hard tissue lesions that are, for the most part, benign, occasionally something more than that. And then other issues that we deal with would be people's can sometimes have jaws that grow disproportionately, and it can affect many things, but specifically can affect how their teeth line up, or a better way to say it is how they don't line up. And that can lead to other problems. It can also affect their airway and their breathing negatively. And so by repositioning their jaws and correcting what the genetic defect was or the developmental defect was, we can improve the functioning of their teeth. And oftentimes that can correct some airway issues, also some facial aesthetic issues. So those are things that would typically be done in the hospital setting. On a day-to-day basis in the office, it's taking out teeth, grafting bone, putting in implants, treating pathology, things of that nature.
I have a question, because you took the wisdom teeth out of both of my children and did a exemplary job. Why do we need to get wisdom teeth taken out?
So it's a great question, and I have a great answer for you. At least I think so. So you're a deer hunter, Tom, right?
Well, not a very good one. I mean,
Well,
people say that a bad hunter equals a vegetarian, and lately I've felt like a vegetarian.
So if you've seen those deer aging schematics where you're looking at the teeth on the deer's jaw, right?
They grind down.
Yep. So way back when, before we were a developed society, we had a very coarse diet, right? And our teeth are bell-shaped. And when your teeth wear down, they become narrower, and then they migrate forward into the jaw, forward part of the jaw, and then there's room for the wisdom tooth to come in, right? So it's kind of a downside of our advanced civilization in our better dental care and our better diets. So very few people have room for their wisdom teeth to come in. And I'll tell you frankly that the real problem is mainly the lower wisdom teeth. So the lower jawbone is shaped kind of like a bucket handle, all right? So in the back part of the lower jaw, it goes vertically, and that creates the jaw joint up by the ear. And as it comes down, it transitions to a horizontal bone that meets in the midline, and the teeth are in the horizontal portion. Well, the lower wisdom teeth kind of get caught at that angle where the vertical portion meets the horizontal portion. And they get wedged right up behind the back or in the neck of the teeth in front of the wisdom teeth. Those are called the 12-year molars. And they occupy a space that normally would be occupied by good solid bone and jaw and gum tissue, which is necessary for the proper periodontal health of the 12-year molars. So having a wisdom tooth stuck there into your adult years of life is the #1 cause for problems and premature loss of your 12-year molars. And that's a tragic thing, because you use your 12-year molars to chew with, you don't your wisdom teeth, because they're buried, or the other name we use for that is impacted. So what happens is that impacted wisdom tooth is sitting there, and the attachment of the gums over the top of it to the 12-year molars is very thin and friable. And it doesn't happen right away, but maybe in the 3rd or 4th decades of life, that weakened attachment thins out further, it opens up, and bacteria now can get down in there under the gums and attack the 12-year molars on the backside. So getting the wisdom teeth out, especially the lower ones at an early age, has several benefits. #1, I don't care what surgery it is, any surgery that happens on a young growing individual, you will heal quicker and better and more completely. So once the wisdom teeth are out in that lower jawbone, that area in a younger individual will regenerate very reliably and very quickly with new jawbone and gum tissue, which is all important for the health of that 12-year molar. The second reason, and this is a pretty important one, is the root development on the lower wisdom teeth. If it's allowed to go to its completion, the roots can get down very close to an important sensory nerve that runs through the jawbone. It's called the inferior alveolar nerve. It supplies feeling to the lower teeth and gums and the lower lip and chin. So if the roots get a chance to grow down around that nerve, it can put that nerve at risk for injury, and you can end up in rare cases with permanent numbness of the lower lip and chin, teeth and gums on that side. So the benefit of taking them out in a younger person is we can get them out before the roots have grown all the way. And so the risk is the lowest. Now, what age is that is probably your next question. And I'll tell you that it's a bell curve. So there isn't one age. I've seen 12-year-olds whose x-ray shows that their root development on third molars is completely, it's completed. It was the craziest thing. And just by coincidence, a 21-year-old that has no evidence radiographically of any root development on their wisdom teeth. So those would be the two outliers on the bell curve, right? The vast majority of the people is somewhere in the mid to late teens. So I think, you know, the jaw growth is mostly done, you know, early on in the teens, mid-teens. If you had a panoramic radiograph that showed that there's no room for the wisdom teeth, that it's okay to consider taking them out at that age, you know.
You know, it seems like that you're in that late junior high to high school when a lot of us parents would talk about, oh, so and so is going to be having their wisdom teeth out, or so and so just had their wisdom teeth out.
Yeah. Yep.
And I know that our kids fell into that same bell curve right there as well.
And mine too. In fact, my middle son had his out by me last year, and they just do so well. And he only needed ibuprofen and Tylenol, and his were completely buried in the bone. So they just do so much better then.
So how was that, operating on your own child?
You know, I have to be careful how I say this because I don't want to sound cocky, but I was very comfortable doing it.
Wonderful.
Yeah.
You've done a few of them.
I've done a few of them. I'm actually the old guy on the block, Tom.
Oh my goodness.
I remember when I came to town and I was the youngest guy around, and you know, you're fresh out of school, you got a bunch of knowledge, you want to prove yourself, but everyone looks at you like, how long you been doing this? And I don't get that anymore. Kind of miss it.
What the heck? You're still looking really good there.
Oh.
We're just hitting our stride, right?
So you know that you're getting older when you start taking out wisdom teeth on teenagers whose parents were teenagers, and you took their wisdom teeth out when you first came to town. And that,
you know what? We're just maturing. That's what you can call it. Where you're maturing now. Oh, that's awesome. You know, and it's crazy how fast that happens. And I'm assuming you're like anyone else in their career. And I know I fall into the same category as that how did I get here? I'm the old guy in every meeting now. And everyone's asking me questions because you have more experience. Hopefully we have some wisdom. And I'm assuming we're talking about wisdom teeth, no pun there.
Mm-hmm.
But so many people come to us, and I'm sure you know you as well. That wait a minute, Dr. Puffer, you have so much experience in this. I need to come to you for advice or to help me train.
Well, when this subject comes up, I tell people that I call myself the farmer's insurance oral surgeon. I know a thing or two because I've seen a thing or two.
There you go. That's yeah. You know what? And so you're not asked them, am I your first patient ever? It's like, yeah, you might be my first patient today, but you're definitely not my first patient.
Yeah.
So what would you have to say if there's one thing that is your favorite to do? Is there a favorite that you have as a surgeon?
So I get asked this question a lot, and you might be surprised by the answer. So when those two people that I mentioned that were instructors of mine that I worked with when I first got out of school, one of them was an amazing guy because he practiced the full scope of oral surgery up until the day that he retired. So he didn't just become kind of locked into one little niche of oral surgery. And I really admired that about him, and I learned a lot about him. And that was always my goal, is to stay current in as much of oral surgery as I could. And so to answer your question, there's not one particular area or procedure that I enjoy the most, but it's when I do a procedure and in my mind, it's like, nailed it. That looks pretty. That looks really pretty, and I really like that. And so it's my goal to make it look pretty. And when it does, it pleases me, and it usually means a good outcome.
That's pride. That's pride, and that's something when somebody cares about what they're doing, that they're going to be not only proficient, but an expert at it, and they take pride in that. That's what I heard you just say.
And I'm sure it's the same for anyone in any job. I mean, you've got to have that ability to look at your work and say, this is good, and take pride in that. And it doesn't matter what you do, you know.
Let's come forward a little bit and tell us about some equipment. Tell us the progression of some equipment in your profession as a surgeon from when you started and some of the great things there are today.
Yeah, another good question, Tom. So when I first came to Duluth in 1994, I practiced with Chuck Baps on the 4th floor of the Medical Arts Building. It was a teeny little 900, maybe not even that, square foot little office. We had not even a fax machine. In fact, all of our correspondences to dentists and doctors were hand typed on a typewriter, not even on a word processor on a computer. In fact, can't even remember the particular computer or first oral surgery software, but you know, when Y2K came along, we were all panicked. I mean, we thought, you know, our world was going to end. And so since that time, you know, obviously we've got computers in every operatory and computers all throughout the office. We have digital X-ray equipment. Just even the anesthetic technique that we would use to sedate someone. When I first started, it was using something similar to sodium pentothal. It's called Brevitol. And it was a true general anesthetic agent, and you were using small amounts. But now that the technique we use is what we call a balanced anesthetic technique, it's so smooth, and patients are so comfortable on it. I mean, it's just been amazing how things have changed throughout time. Even monitoring equipment. When I first started, we just had a manual blood pressure cuff and a pulse oximeter. Now we have a full Criticare monitor with automatic blood pressure monitoring, pulse oximetry, CO2, end-tidal CO2 waveform, capnography, EKG. So, you know, we're basically an outpatient surgery center. As far as diagnostic equipment, you know, the digital x-rays. So the digital x-rays are great because you get instant imaging. You don't have to wait 10 minutes for a film to develop. We don't have to deal with those caustic developing solutions. And then in 2007, we got our first CT scanner in our office. So it's called a cone beam CT scan. They basically design them for oral surgery offices, even though, you know, many general dental offices have them as well too. But it's really been a game changer to be able to see things in 3 dimensions. So just give you a quick example. Let's say I have an adult patient that comes in and they've been referred for removal of a problematic lower wisdom tooth that they wish they would have now had out when they were a teenager. And on a 2-dimensional x-ray, we see that the roots go down deep enough to where that nerve canal is. In fact, there might be some radiographic findings that are really suggestive of a very intimate and potentially risky association between the root and the nerve. So we get a 3D CT scan of that, and we can evaluate that in 3D. And we can make a better clinical decision as to how to best treat that tooth. Okay.
So prior to versus getting in there and seeing or figuring this out.
Right. So it helps the patient to be informed about their risks and their options. We do have options. Short of taking out the whole tooth, we can take out part of the tooth and leave the roots that are down around the nerve. That's called a coronectomy. But prior to the advent of that in-office CT scanning, we just kind of had to fly blind in a lot of instances. So that's a huge game changer for us. Nowadays, and general dental offices have had this in their armamentarium and have been using it a lot more than oral surgeons. But instead of taking an impression where we put the goop in the tray and slap it in your mouth, we can just shine a light at the teeth and we can take a digital impression.
No kidding.
Yeah. In fact,
all of us old people who were gagging on that impression material in the past don't have to do that anymore.
Right. So now we even have at our hands an entirely digital workflow from start to finish for a patient who's going to lose a tooth and have a dental implant placed. So we can take an image, 3D image of that part of the jaw and their tooth ahead of time, scan their teeth, send that all off to a lab, do the surgery, come back, have a guide made to guide the implant placement, and then take a scan of the implant when it's in the jaw, send that file off to the lab. The lab can make the tooth part that goes on it, and it just is another way to do this process and streamline it, but reduce the number of patient appointments for the patient's benefit and for the general dentist's benefit, and arguably maybe in some cases or many cases provide a superior end product for the whole dental team for that patient.
So technology's come a heck of a long way in 30 years.
Yeah, it's scary what might be coming down the road. I mean, it's just amazing.
So let's come forward a little bit. And what advice would you have as a senior person who's been doing this for a long time? And I don't mean senior in years, but you're the senior partner of your business.
I'm also senior in years.
Well, you know what? I'm not going there. What advice would you give to somebody who is interested in what you do for a living, and what would you tell them? They come to you and they look to you as a mentor.
So I'd tell them, go for it. If this is what truly interests you, go for it and don't stop. And I would say, come spend some time in our office. In fact, 2 of my current partners did just that when they were in college and dental school. They came and they observed us work and watched us work, spent some time shadowing us. So, I would say go for it. It's a great profession. There are many things that are enjoyable about it. The things that are frustrating are maybe few and far between, but you're going to find that in any line of work.
Probably insurance companies.
That
and paperwork.
That and the paperwork, yeah, because it sometimes seems like there's some things with digital record keeping that we were more efficient and when we were using paper charts, and the whole idea of being paperless is just a myth. Because even though we have digital record keeping, we still develop a paper chart for every patient that walks in. It just gets scanned into the digital record. So now, we're just duplicating things. So our efficiency has gone down since we went digital record keeping. But that's just one small aspect of things.
And every career is going to have its pluses and its minuses. Right. And I know that anyone in the medical fields that I have personally ever talked to, their favorite part is working with patients, delighting patients, helping patients feel better, do better, versus the paperwork that then has to be done. I've never heard an answer any different than that, Duncan.
So can I add to that just a little bit?
You sure can.
So when I was young and fresh out of school, and I thought, I have all this knowledge that I just can't wait to unleash on these patients and stuff. And I think it's a common mistake for a younger practitioner. What I'm finding now is that after having practiced this long and done these procedures so many times, is I still want it to look pretty, right? I still want it to go as best as possible. But I find that I'm enjoying the patient interaction way more than I ever had time to before. And maybe I was just too young and stupid to realize the value in that. But I really do enjoy the patient interaction. And there are many different aspects of that. One is just people are interesting. People come from interesting walks of life, and they have interesting things in their life that I don't have in mine, and it's fun to hear about it. Sometimes we have things in common, and it's fun to hear about that. But my favorite thing is, and I think I'm way better at this now than I ever was before, and I think there's the fact that I've been doing this so long, is I really like the really anxious patient. And when I was younger, I didn't. But I have the confidence of having done this for so long, and I really think I can impart that to them, that we got this together. We'll get you through this. So it's really fun to get an anxious patient through something and have them kind of smile afterwards and say, "Man, that was not as bad as I thought it was going to be." I mean, that's very rewarding.
I think that's wisdom right there.
Yeah, it's just fun. I mean, it means that and it's not just me. It's the people I work with, because I have other people in the room, and I can't do what I can't do what I can do unless I have really good people to assist me. I can't do it by myself. So they're every bit as much a part of this as I am. So it's a kind of a teamwork approach in our clinic. It's just fun when we have nervous patients like that, whether they're young or old, and we get them through something like that.
That's awesome.
Yeah.
Tell us a little bit about COVID, how it impacted your business. Everybody's been impacted, and every business has been impacted differently.
Well, our cost of business has gone up tremendously, and we spend, I think in one office alone, I don't know if I'm supposed to say this, but I think it's like $60,000 a year just in launderable gowns that we have to wear, according to the CDC and the Minnesota Board of Dentistry. So it's a huge added expense. That's one thing. The second thing is that we were basically shut down except for emergency care. And many dental offices were the same. In fact, there was so much fear and uncertainty in the early days of COVID that there were some dental offices that just weren't seeing any patients. And part of that also was they didn't have enough personal protective equipment to be able to see the patients. So at times we'd get inundated with a lot of patients. So we were open during the whole COVID time. In fact, I worked closely with Essentia and St. Luke's, put out some public service announcements that were on the radio, as well as in the print paper and even on television, to kind of educate the public. Don't go to the emergency room if you have an acute dental emergency. Go to your dentist first. So our mission was to keep these patients out of the emergency room, because we didn't want to, because the emergency room resources were so limited, and we knew that they couldn't really provide the acute dental care that was needed, but we could. And the hospitals were trying to minimize their exposure to COVID patients. So that was an important point of emphasis for us in the early days. But we stayed open, and we would limit the number of patients we would see. We would be fully gowned and double masked and shielded. In fact, it was completely miserable. I mean, you can hardly breathe. Your mask is fogging up, It was something new. It was just, there was a lot of kind of stress and anxiety, but we got through it. For doing consults, normally we would do those in person, but instead what we started to do is phone consults. So we would have an x-ray, we'd have them fill out their medical history online, we'd give them a call and discuss what we see and what their options were, and we would kind of triage them. Is this a true emergency, or is this a dental urgency, or is this something that could wait? And many of the ones that could wait, like wisdom teeth and things like that, we just had lined up on the books and ready to go once once we were allowed to treat elective cases, which happened in very late May of 20. So we had all these surgeries lined up, and we just hit the ground running then at that time. But dentists and dental offices, we're kind of the canaries in the coal mine. We're in people's faces. We're doing aerosolized procedures. If anyone's going to get COVID, it's going to be us.
And I've heard that from other dentists.
And it's a surprisingly low number of dentists or dental professionals that have got it. In fact, I don't really know of anyone. I actually ended up getting COVID about a year ago exactly. I got it from my middle son, who got it from his girlfriend. Brought it into our house, and so I didn't even get it from work. But
and that's where your highest exposure is at work.
Yeah, but actually, I'm thankful that I got it and survived, and I think there's something to be said for natural immunity. I've subsequently been vaccinated, so I'm probably doing pretty good in that regard.
Raging with immunity at this point.
Yeah.
Duncan, you serve as the president-elect for the Duluth Dental Forum, which is the second oldest dental study club in the country.
Yeah.
Tell us a little bit about that.
Well, I can't tell you a whole lot about the history of the Dental Forum, but it's a by invitation study club. And I can't even tell you how many years I've been in it, but it's a great group of about 20 to 30 of us. And there's a lot of history there from the older people that were in when I joined, and now I'm kind of the old guy there, and a lot of young people are there. But we have continuing education programs throughout the year from September through May. And one of my favorite ones happens in April, and we sit around a big round table and everyone presents a little pearl of the trade, a little something that they have discovered in their daily lives or in their office that makes a particular problem or procedure go better. And so it's really a nice collaborative sharing of information. So it's kind of a fun study club. So we have a educational meeting, and then we have a business meeting, and then we have a dinner, social hour and dinner. Meets once a month during the school year. I did go through the officers. I'm not president-elect currently. That's old news. That's from times past.
Okay.
But yeah, so I have done that.
Well, that's awesome. So we're going to switch gears a little bit here.
Okay.
So Duncan, everybody, is also a personal friend of mine, and this guy can shoot a bow and arrow like there's no tomorrow. Let's talk a little bit about bow hunting. When did you first get into bow hunting?
So we'll have to go back to the year 1982 when I graduated from Gustavus, and I was home working for the summer, studying for my dental admission test. And my very best friend, John Flaherty, who grew up right next door to me, I was sitting in my downstairs bedroom, and I heard this noise coming from the next door, and I heard this thwack, thwack. And I was curious, so I went outside, I walked over, and there's John shooting arrows into a hay bale. And he had gone and bought himself a compound bow and some arrows. And I thought, and we had talked about this a little bit, and I said, I got to do this. So I did. I went out and bought a bow, and John had some hunting land they had permission to hunt on, and in Wisconsin, New Richmond, Wisconsin, and I kind of invited myself along, and we hunted that place for years. It's a great way to be outdoors. In fact, John and I talk frequently, and just within this last week, John made the observation that it was probably that those early childhood years growing up with that big dairy farm behind us, the ponds, the trees, the woodlots, that really instilled in us the joy of being outdoors and hunting. My father didn't really hunt much. He didn't take me hunting. I really learned that, and everything I know, most of the stuff I know from hunting, from my buddy John. He was the leader. So, so I bow hunted starting in 1982.
So what would you say is your favorite part? And I'm an avid bow hunter as well, and Duncan and I have personally had these conversations. But for our listeners, what would you say is your favorite part about bow hunting?
Well, there are many things, but you might be surprised. Actually, killing an animal is the part I like the least. I enjoy eating venison. I enjoy eating elk even better. I enjoy eating turkey and pheasants and grouse. If I don't enjoy eating it, I'm not going to hunt it. In fact, I tried my hand at black bear hunting and I didn't enjoy the meat and I quit.
And that's a good lesson. What you just said is a very good lesson for people who don't understand the hunters. And one thing you said there, and I can tell you I'm in that exact same boat, is and people will say, well, then why do you kill the animal? Well, we can't eat it if we don't. But that's shooting the animal is not necessarily what trips the trigger for hunters. It's the experience of being in the outdoors, the conservation experience, seeing animals, all of the things. And I'm a big advocate of, and I kind of get on a soapbox a lot of times when people are talking about that. But I think you hit on something right there,
Yeah.
And that is the table fare.
And I'll just add to what you just said. I mean, I have so many really cool memories of things that I have seen sitting in the bow stand you might not see sitting in a rifle stand. The reason I say that is in a bow stand, your end game is going to happen within a very short distance compared to in a rifle stand. The end game meaning taking of an animal. And in order to have that happen successfully with a white-tailed deer, probably the most cautious animal in the woods, you have to be able to sit still for long periods of time. When you do that, you have really interesting things that you get to observe. Flocks of turkeys come walking through, coyotes, fox, barred owls landing on a branch on a tree away from you and start hooting. Chickadees land on your bow or on your arrow. Pine marten. I was sitting one day in late season, snow on the ground, and I sat from sunup to sundown. And at sunup, I watched a pine marten come trouncing through the snow, and he climbed up a tree that was about 20 yards away from me, crawled in a little hole, and slept there all day. And at about dusk, a little airplane flew over, and I saw his head pop out of the hole, and he climbed on the tree and he went off hunting. So, there's things like that. There's a time I was walking out to the stand in the snow, and I saw where 3 otters had come through the lowland. There's a little creek there, and had hopped and slid through the snow. And there's just so many cool things that you miss unless you have that opportunity to sit out in a tree stand like that. I would say, even if you don't want to kill an animal, even if you don't want to hunt with a bow, just go sit in a tree stand. It's amazing. Sit with a camera. You'll get some great pictures of some really cool stuff. So I just like being in the outdoors. I can tell you, and I know you probably feel the same, Tom, that nobody gets bothered more by litter and trash and stuff than a hunter. I mean, we seek out those pristine places because of their inherent beauty and because they are good habitat for the game that we like. And nobody cares more about protecting the environment, I think, in my mind, than people who spend a lot of time out out in it hunting.
I could not agree with you more. It drives me crazy, but if I see a sandwich bag or I see a candy wrapper or I see a pop bottle or a water bottle laying out in the woods when I'm on trips or I'm hunting, I will pick them up every time and carry them back with me and put them where they should be instead of in the environment. And I think that we also are huge environmentalists and conservationists probably first, and give back to the wildlife more than most.
Animals are going to not live forever. This is going back to so it's not a question if animals are ever going to die. They are. I like to think if I can respect one enough that I can humanely as possible harvest that animal for my family and my table, I think I'm doing something good. I honestly think if more people took an active role in procuring their nutritional needs on a daily basis, our world might be a better place.
I agree, and I can also tell people that we have a pheasant casserole recipe you gave to us because you would have a game feed at your house, which I have been at several times, and that pheasant casserole recipe is one of the favorites. We're going to switch gears again.
Okay.
In 1 hour, we're switching gears a bunch. Duncan, this is called our packed question segment. And we're just going to rapid fire here at you a little bit.
All right.
Because we want to get to know you as a person. Favorite movie?
Jeremiah Johnson.
Why?
It's kind of a cult movie. I saw it at a very impressionable time when I was a teenager, when I was just getting involved in the outdoors. And it was great acting, and my two best friends, Raleigh Johnson and John Flaherty, and I just kind of would watch that over and over, and I practically have the darn thing memorized.
Who would you love to see in concert?
Oh, there are so many, but I did check off a major one on my bucket list a few years ago. I saw George Strait at the T-Mobile, and he was awesome.
And you're a big country music fan.
I'm an all kind of music fan, but I think country is special because it tells a story, and there's usually a repeatable melody that I can remember.
Folks, today's very special guest has been Dr. Duncan Puffer, board certified oral and maxillofacial surgeon. Boy, that's a tongue twister for me, isn't it?
Yeah.
And senior partner, Northern Oral and Maxillofacial Surgeons, PA. Duncan, we thank you so much. This has been really enlightening to find out what goes into your world every day, and all of the schooling and all of the knowledge and wisdom that you have to bring forth every day to take care of your patients. And you made it very clear that your patients come first.
Thank you, Tom. It was a pleasure to be a part of this, and it was a big honor.
Again, if you are in the Duluth, Minnesota area, it's Northern Oral and Maxillofacial Surgeons, PA, Dr. Duncan Puffer, our special guest. And folks, until next time, unplug from the indoors and recharge in the outdoors.